Okay, everybody, a big warm welcome to you all, and thank you for joining us this evening. My name is Peter Hilton, and I am the Training and Engagement Officer for Glaucoma UK, covering the north of England, Northern England. I would like to introduce Rachel Hilton, our Glaucoma Nurse Specialist from Manchester Eye Hospital. And for this session, we are going to focus on narrow angles and primary angle closure glaucoma. I'm just going to launch a quick poll now in a moment to see what knowledge you have at the start of the session. So if you bear with me a moment, I shall do that. The poll is launched now. If you're working with a screen reader, it will make a ping. Don't forget to submit. Great, I can see you're all putting your answers in there. That's fantastic. I'll let it run for a little bit longer so everybody has a chance. And welcome to everybody on our social media platforms as well. I think I will end the poll now. It looks like the majority of you have answered so far. So thank you very much for that. Just bear me a moment. So please don't forget to ask any questions in the Q&A function if you're on Zoom. Please like any questions you like so we can answer the most popular ones. And if you're watching this live on our social media platforms, please ask your questions in the comments and they will be fed into us here for us to answer. So we've got about an hour today. If afterwards you need more information or support, we'll touch on how you can get that at the end. So it gives me great pleasure, without further ado, to hand over to Rachel now.
Hey, hi everybody. I'm just going to try and share my screen. So hopefully you can see that. So if everyone can see that okay, I'll begin so we have plenty of time. So I'm Rachel. So I'm a glaucoma specialist nurse at Manchester Royal Eye Hospital, and today we're focusing on talking about narrow angles, primary angle closure glaucoma. So I just want to touch on what glaucoma is in terms of its sort of general characteristics. Obviously, we're speaking specifically about one type of glaucoma today, but when we talk about glaucoma, it's important to note that there are lots of different sort of causes for this particular condition, and that's why we have these different diagnoses. So always in glaucoma, we're saying that the patient has glaucoma when they have actual nerve damage. So there might be other sort of anatomical things going on within an eye that make somebody at risk of having glaucoma. But when we say someone has glaucoma, that optic nerve is thinning. So optic neuropathy, thinning of the optic nerve, can cause and will cause loss of vision. So what's happening is your nerve is made up of millions of nerve fibers, and in an eye with glaucoma, those nerve fibers are dying off at a much quicker rate than sort of a natural aging process. So as we lose that fullness of the nerve, we lose the ability to be able to send those sensory nerve impulses as messages to the brain to interpret the image that we're seeing. So as you can see in that image at the bottom there, hopefully, if that's clear enough, there is a picture of a nerve and an arrow pointing to another image there. So that's to show that where a nerve becomes thinner, there will be a corresponding visual defect. And that may be very subtle in early stage glaucoma, but that will eventually be present. So as we see a nerve thinning, we expect there to be a visual change. And usually it happens on the peripheral areas of the vision. And then if that's left to progress, that will encroach more and more. And this is why sometimes people hear about tunnel vision and glaucoma, because it tends to be that the central part of the vision is the sort of last part to go. Unlike some other eye conditions that can affect the central vision, on glaucoma, it's peripheral edges encroaching in. It's not a curable condition, as in we cannot regenerate an optic nerve once it's damaged, not at this present time. So we're always working in a preventative way to try and avoid the nerve from becoming further damaged. So in that sense, unfortunately, we can't bring back vision that's lost. However, it is something that we can treat very well. And actually, if patients are referred in, the earlier the condition is diagnosed, the better, because then we can get on appropriate treatment and hopefully protect that vision. And I'm going to talk to you specifically about the narrow angles and angle closure glaucoma today. However, a lot of the treatments we use for most of the glaucomas, to be fair. So just to talk about risk factors, there are general risk factors when we talk about glaucoma, any glaucoma, such as increasing age, family history, and ethnicity. So certain ethnic groups are more prone to certain types of glaucoma. Family history and ethnicity, of course, relate to sort of genetics. And then raised intraocular pressure, I've put in there in sort of bright red because actually of those 4 main risk factors, the raised intraocular pressure is the only one we can really change and do something about. The higher the eye pressure, we know, the more mechanical stress we'll have on the nerve, because if the pressure is built up within the eye, that nerve at the back, it's going to push on there and it will potentially affect those nerve fibers and cause them to die off a lot quicker. So raised intraocular pressure is a very important risk factor because it's the one thing we sort of focus on. Specifically with narrow angles and angle closure glaucoma, there are other risk factors such as females being more prone to developing this condition. And in East Asian populations, we're far more likely to see this narrow angles or angle closure glaucoma. If the eye is very sort of short and packed together, so for patients who can see in far distance more easily, that anatomy is a sort of a risk factor for the development of angle closure or narrow angles, as is a thicker lens and a thicker iris. And I'll explain a bit more about how those anatomical features can lead on to this problem. So they're additional risk factors in relation to what we're talking about today. So I've talked about the IOP being super important. With any glaucoma, we're aiming to try and reduce that eye pressure to keep the back of the eye protected. So a normal intraocular pressure is 10 to 21 millimeters of mercury, a sort of textbook normal. How that pressure is controlled is through something called aqueous humor, and that's made at the ciliary body, which you can see labeled on that image there. The aqueous humor flows in front of the lens, which is that sort of elongated oval shape there, and through the pupil, which is the hole in the iris, and sits behind the cornea. And that fluid circulating in that area to provide nutrients and take away waste products. And that helps to keep the shape of the eye, but it importantly helps to maintain the intraocular pressure. What should happen is the fluid's produced and it goes through that route and circulates there, and then it exits the eye again. And the rate of which it's produced against the rate of which it drains should be in balance. If it's not, then you will get a rise in the intraocular pressure. There are lots and lots and lots of things that can affect the IOP, the intraocular pressure. I've listed some there. Time of the day will naturally go up and down, and for some people that's significant. Certain medications may affect things. The corneal thickness is an interesting one, because actually when we're measuring the thickness of the cornea, it's important for us to know how thick or thin a cornea is, because if the cornea is particularly thick, we have to apply a lot more pressure when we're measuring the eye pressure. We do that by something called tonometry, which you can see at the top there. It's a prism pressing on and flattening the very front of the eye, the cornea, to gauge the internal pressure. And if it's quite thick, we tend to get a higher pressure reading. If it's quite thin, we tend to get a lower pressure reading, and that can actually lead us to believe that the pressure is lower than it truly is. So there's lots of things that we might consider when we're looking at these pressure readings, and sort of whether there's anything else that's affecting it rather than the pure anatomy. However, those anatomical structures and whether or not the fluid's draining away are really important, because ultimately that's usually where the main problem is. So just to talk about that and how that fluid is draining away. The normal route, as I just mentioned, is the fluid produced by the ciliary body, it flowing through the lens, which you can see there. You've got that blue arrow trying to show this. It goes through the pupil, the hole in the iris, and then it exits. Now, it exits where the cornea and the iris meet at their peripheral edge. So if you imagine you have those two structures, one in front of the other, the cornea at the front and the iris behind it. Where they meet 360 degrees the way around at their edges, that is what we call the drainage angle. And within the drainage angle, you have some structures that the fluid has to pass through in order to reach the episcleral veins and be absorbed back into the body before it makes another cycle again. So those structures that you can see at the top there, one is called trabecular meshwork. That's that sort of stringy, spongy-like structure. And the other one is canal of Schlemm, which is that sort of oval-like structure. There can be issues with those structures themselves and the fluid getting sort of clogged up in there, not passing through as easily. For patients who have open angle glaucoma or an open angle, but have issues with the pressure being high, usually what's happening is the aqueous isn't flowing through that area as well. It's getting blocked up, and that's still giving a rise to high pressure. For patients who have narrow angles and ultimately angle closure, the problem is occurring before the fluid even gets to that drainage system. It can't access the drainage system in the first instance. So where the cornea and the iris are very tightly packed close together, we're going to run into problems with the pressure going up because actually it can't even make it to those structures. When we're looking at patients to see if they have an open or a closed angle, we may use a lens on the surface of the eye, and that's called a gonio lens, which you can see in that image, because what that'll show us is how open that drainage system is 360 degrees all the way around. So you have a full mirrored lens, and you'll be able to see at the top, at the bottom, and left and the right to see whether there's any risk of closure there. So we're looking to see whether that cornea and that iris are very, very closely packed together. When it comes to the actual diagnoses and classifications of glaucomas, it can get really confusing. So for anybody who's been told they have narrow angles, angle closure glaucoma, hopefully this sort of helps to put into perspective the different classifications of this sort of subset of glaucoma. So if you have narrow angles, we'd be saying you are a primary angle closure suspect. So what that means is the cornea and the iris are very tightly packed together. There is some occlusion there. The fluid's not able to easily access the drainage system. But importantly at this point, the angle is just narrow. The pressure is still normal, so there is some access there, and the optic nerve isn't damaged, and the visual field is normal, so vision's okay. If we then say somebody has primary angle closure, there is definitely some occlusion there, as in the iris and the cornea being tightly packed together and closing that drainage angle off. And now we have an increase in the intraocular pressure. The field test, however, and the optic nerve, so vision and the nerve itself, are normal. No changes there. So this is not a glaucoma at this point. If we then say somebody has a primary angle closure glaucoma, we're saying that all of those other things are present. The angle's closed off, the pressure is raised. However, we now have that optic nerve change. So we've now got that damage to the nerve. So that's your sort of categories of the types of narrow angle or angle closure or glaucoma we're talking about. And another image to try and demonstrate that. So often patients will sort of ask, why is this happening? And certainly, why is my eye okay for a long period of time? And then it suddenly goes into this closure, or somebody suddenly found this. Well, if somebody has narrow angles, then the narrow angles are there. It's just that it may only be picked up at a routine optometrist visit. However, the mechanism of action for somebody having a full closure and that drainage system being closed off, the most common one is something called pupil block. So what's happening, and hopefully you can see this in the image there, as that fluid is trying to make its way to the pupil, because the normal route would be it's produced at that ciliary body, goes in front of the lens and goes through the pupil. If that area is quite tightly squished together and it can't get a lot of it through the pupil, more of that fluid builds up behind the iris. And then what you get is this pushing of the iris forward against the cornea and blocking off the drainage system. So that's what we would call pupil block. And it's the most common mechanism of people going into this angle closure. The other two I've listed as a primary mechanism for a primary angle closure is iris angle crowding, so that the iris, where it's quite thick, as the pupil dilates and that sort of draws back to open the pupil up and make it bigger, you get this again squishing against the cornea, blocking of the drainage system. And plateau iris syndrome is just to do with, again, the iris formation. And if it's not necessarily thicker, it's positioned in a bit of an odd way where it's a little more sort of forward on the ciliary body, where that aqueous is being produced, or the ciliary body is turned a little bit. And overall, again, it just means anatomic, as the pupil dilates, you've got more risk of that pushing back and closing off the drainage angle. There are other reasons why people may go into angle closure that are secondary causes. So all of the ones I mentioned, it's purely just the anatomy of the eye, and we call that a primary glaucoma and primary angle closure. There are lots and lots of secondary causes. Things like a cataract forming as the lens becomes more filled with proteins, it becomes larger, takes up more space within the eye, it pushes all those structures forward and again closes everything together. And that can cause an angle closure. In diabetics, where we get new blood vessels growing, they can grow into the anterior chamber, and that can cause issues with the drainage system. So if there is a secondary glaucoma, we obviously want to try and treat the primary cause. So, try and get diabetes under control, for example. But if that's not there to look at, then we're purely dealing with just the way the anatomy is, and that's a primary glaucoma. So I've sort of mentioned this in terms of what triggers it, what sends people into this attack of being aware that they've got this problem. Often it's pupil dilation, so that could be we've given medications, or we've given a topical dilating drop, or patients gone into a dimly lit area and they need more light in, so the pupil will naturally go a bit bigger. It can be stress or excitement, but something that triggers a dilation of the pupil can start this off. People do worry about medications, and there are a fair few medications that may be contraindicated in terms of angle closures, narrow angle, purely because a lot of them have this dilating effect. So I've listed there, obviously, dilating drops will dilate the pupil, some antidepressants, some medications for schizophrenia, some medications for epilepsy, asthma, for anti-sickness, etc. Interestingly, steroid medications, they do raise intraocular pressure, or can do. However, it's not something specific to narrow angles or angle closure glaucoma. It's just something we're aware of in general. So any patient with glaucoma, we may be cautious about steroids, but I can't say that this is something that would cause an angle closure attack as such. So what do we do when this happens? So the monitoring treatment aspect. So it's important to note that if somebody has a full angle closure where it is completely closed off, and that's an acute primary angle closure attack, then the most common cause is always pupillary block, pupil block, and it will be something that most patients are very symptomatic with. So usually patients will be presenting at an emergency eye department or with their optometrist because they will feel a lot of discomfort and the vision may change, and it is an ocular emergency. So we would fully expect patients to present with these symptoms, and we would want to treat this very quickly to avoid it developing into glaucoma. We want to avoid that nerve damage. Because what happens in a primary angle closure attack is the pressure goes up rapidly. So rather than having a pressure between 10 and 21, they can go as high as 50, 60, 70 millimeters of mercury, very high. You do get these other categories of these subacute angle closures. So this can be related to the pupil dilating and then actually normalizing to a regular size. And people will get symptoms with this, but they won't be as severe because ultimately it subsides, it doesn't continue. And that may be because the patient has done something to alleviate that without realizing potentially, but you can get these subacute attacks. And you can get chronic primary angle closure glaucoma. So when this is happening, you've got more of an insidious, slow rise in intraocular pressure. It's all to do with the angle and the fact that the fluid isn't draining as easily. However, unfortunately, patients may be less aware of symptoms because it's a slower increase in intraocular pressure. And again, a lot of these things is picked up by optometrists who are doing routine sight tests for spectacles, or someone perhaps is having their eyes looked at for another reason, as it's not symptomatic, which is usually the case for open angle glaucoma, which is often asymptomatic and people aren't aware. However, if somebody has that acute primary angle closure attack, they will present, as I say, because they'll be symptomatic. And the signs and symptoms to sort of look out for are pain, so pain in the head, around the eye. The vision will be blurred because the eye is just filled with that fluid. So it can cause an odd haloing effect when looking at lights, but it certainly can cause blurry vision. The eye will look red because it's all inflamed as you've got all that pressure within there. It can cause nausea and vomiting. The pupil won't look like it's be able to change size, so often it's fixed at mid-dilation, and definitely the pressure will be higher. So we do try and obviously treat these symptoms and give anti-sickness medications, pain relief, etc. But ultimately, we need to get that pressure down rapidly. So we will give drugs either IV and or oral. We tend to do IV and then also give a tablet form as well. Drugs that stop the aqueous humor being produced as much, so it reduces the amount of aqueous. They often work as a diuretic as well, so actually the patient is excreting more fluid, which drops the pressure overall. Eye drops that we give, again, we'll give drops that reduce the eye pressure. Often, a lot of them are stopping the aqueous from being produced. And actually, we may give a steroid drop even to reduce the inflammation in the eye. And we will usually do a peripheral iridotomy laser, which I'll talk about in a moment. So this is just another slide to show the various drug groups available. Again, we use all of these to treat open angle glaucoma. They're all pressure reducing eye drops. But obviously it's very helpful to try and decrease the amount of aqueous being produced, which a lot of these do, in order to stop there being that buildup. Diamox that I mentioned, the acetazolamide, is the IV medication we give most typically, and we can also give it in oral form. And we give that when somebody is presenting with an acute attack, but we may actually send patients home with this medication. However, it's not something we like anybody, whether they've got an open or a closed angle glaucoma, to be on long term, because it causes a lot of side effects. So there are numerous ones, but tingling in the hands and lips and feeling quite tired. Some people will say it gives them, gastrointestinal upset, headaches, etc. So we don't like people to be on it. It also is contraindicated really in patients with renal issues, with kidney problems. So it's a short-term fix ultimately. We want to try and prevent patients from having these angle closure attacks and keep the pressure low. So we would usually do this with a laser intervention and possibly a surgical intervention, which I'm going to talk about now. So the lasers that are available to us, the more common one is a peripheral iridotomy. So with this laser, we create a little hole in the iris, and it helps to have all of that fluid flowing through another hole other than the pupil. So we were talking about pupil block before. If the pupil is effectively blocked because the fluid isn't able to access it as easily, and you've got that build up behind the iris now, if we create another little hole at the top in the iris, it allows all of that fluid to pass through. And then what it hopefully does then is prevents this full angle closure, because actually that releases some of that pressure that's building up behind the iris, pulls the iris back away from the cornea as it was getting pushed against. And that works very well to avoid angle closure. In patients that have the kind of oddities of the iris, if you like, anatomically, it may be, particularly if it's a plateau iris, that it's more suitable to do something called argon laser peripheral iridoplasty. So what that's doing is it's a laser that works all the way around the iris. It thins it out and pulls it away from the drainage angle. So as I say, it does depend on the reason, the mechanism for patients being at risk of going into angle closure. Pupil block is far more common, which is why we do the peripheral iridotomies a lot more than we do the argon laser peripheral iridoplasty. And this was an important one that I thought I wanted to try and squeeze this in, although it is quite a busy slide, because there is a study, the ZAP study, where patients were enrolled on it and they had peripheral iridotomy in one eye and then just no treatment in the other eye. We could treat with drops if needed, but no treatment essentially. And the idea is this study was trying to see if it was beneficial to prophylactically treat an eye who may be narrow and maybe at risk of angle closure with a peripheral iridotomy. And actually, before this study, historically, that it was definitely the case that they would offer this a lot more. Nowadays, since this study, it's kind of slowly making a shift towards not doing as many peripheral iridotomies unless we really need to. And the reason for this was because the number to treat, so how many patients we'd need to treat in order to benefit one, was 44 to 1 patient. So we'd have to treat 44 patients in order to see some benefit with just one patient, where we prevented one patient from angle closure. Over 6 years. So actually, because there are always risks with anything we do to an eye, it was found that the risk may not outweigh the benefits unless there was a high risk of patients losing vision, and there was a need to potentially do this for certain groups. So this is where the PACS Plus guidelines came in. And actually nowadays we may say to somebody with narrow angles, we want you to be aware of the possible symptoms of an angle closure, but actually if you're very low risk, we may not need to do a peripheral iridotomy, for the sake of doing one, because you are so low risk. However, in patients who that may be their only good eye, so to speak, visually, we may be more inclined to do it for vulnerable adults who might not report if they have those angle closure symptoms, if there's a significant family history there, if certain medications need to be used that we can't take a patient off, etc. Then it may be advisable to still do that laser peripheral iridotomy. We do have other options as well, and the other option besides medications and lasers is surgery. Now, there are many glaucoma surgeries, and I would sort of say ultimately it may be that if there's persistent problems with eye pressure, because we may treat the initial issue of the angle being narrow and closing off, and actually there still may then be issues with the pressure within the eye, and we may need to go down the other routes of other surgeries to keep that drainage system open. But when we're talking purely about narrow angles and angle closure glaucoma, the one surgery that comes to mind is cataract surgery or clear lens extraction. So there was a big study called the Eagle study, which was basically looking at whether or not it would be of benefit to remove a patient's natural lens and replace that with the artificial lens, which is what we do in cataract surgery, but do that earlier than when the cataracts form for patients who have this narrow angle. So the idea is, as I mentioned earlier, when you have a cataract forming, it takes up more space within the eye. And so if we can remove that sort of blockage, if you like, that sort of bigger lens that's formed, remove the natural lens and replace it with a flat artificial lens, we're essentially just doing the cataract surgery a little bit earlier than we perhaps would have in another eye. And it gives us more space there. It opens up that drainage area. And they found that this was really successful, and patients, improved in their quality of life reporting. So they said that they preferred this, and I think it was because it was reducing the burden of eye drops. That's mostly what was reported. And obviously they preferred the fact that the vision had improved because we'd taken away any potential early cataract that was forming there. And so vision was better, and actually the pressure was shown to be better. I can't say that this will be recommended for everybody who has narrow angles. However, there was a lot of benefit found in doing this, particularly if we are going to be removing the cataract anyway. But it really does depend on each individual. And obviously, when we say somebody has a primary angle closure glaucoma, where there's definitely that nerve damage there, they'd be more likely, I think, for most providers to go down a route of surgery than somebody who purely just has narrow angles, because any surgery does come with risks. But this was shown to be a good and relatively safe option for patients who have these narrow angles. So that is pretty much it for what I was going to sort of discuss. I'm sorry if it's a bit wham bam, but I have checked with Peter that this is all available to kind of go over again. So I guess now it's just, if there's any questions, I will stop sharing my screen.
Fantastic. Thank you, Rachel. That was really insightful. We do have a few questions. The first one is, came in beforehand. What can I do to help myself if I've got one of these conditions?
So this is always really difficult to say because there isn't a great amount. It's more about being aware of the possible signs and symptoms. So certainly I would say, if you're not under a hospital and you're just having your regular sight tests, do go for those regular sight tests. Because as I mentioned, if it's purely that the angles are narrow, but you've not had any other issues there, most people aren't aware of that if they've not gone into angle closure. So going for a regular sight test means you at least are aware that that's happening. It will be then your optometrist can keep a regular check on if anything looks anatomically like it's changing and maybe your risks change. And certainly if you are under a hospital, then make sure you're going for those visits and keeping a watch on what's going on, because we will keep people under our hospital systems who've had an angle closure attack, who definitely have the glaucoma there. A lot of narrow angle patients are back in the community with their optometrists. So it's more being aware of those symptoms, making sure that you tell us about any medications you're on as well, because of course that's another risk factor. So if we can adjust medications or speak with your GP or other provider about adjusting medications, we can do that as well. But unfortunately, there's not a lot in the way of lifestyle changes that you can do. It's just the way the anatomy is with these conditions.
Great, thank you. The next question, I noticed the mention of bananas, potassium. Is this a good thing or a bad thing?
Oh, as in, we would say we want for some patients who are on the acetazolamide, so it's about increasing those potassium levels. So it's the bananas to reduce the side effects, basically, some of that tingling and so on. So often you might have people say, oh, increase the amount of bananas you're having to reduce side effects. That's what that's about. It's not specifically about the angles, it's more about the diamox, the acetazolamide, that's the other name for it, and how to combat some of those awful side effects that can give you. So that's why.
Oh, thank you. Excellent. Right, the next one, I'm going to have to spell one of the words here. And can FUCHS and then it's endothelial dystrophy affect IOP?
So the Fuchs dystrophy, I missed the other bit in between.
Can the Fuchs endothelial,
Oh, endothelial,
ENDO?
sorry, just the endothelial dystrophy.
Okay,
Um, so not as such. So that is affecting the cornea. So it's not necessarily going to give rise to, to eye pressure changes as such. So yeah, it's more the corneal issues of the vision that's affecting.
great. Thank you. So the next question we've got, how does normal tension glaucoma affect the angle? Is it open or narrow?
So with normal tension glaucoma, we're usually referring to that as being a normal eye pressure with an open angle. So yeah, if somebody has glaucoma, so when we say it's normal tension glaucoma, the nerve is getting damaged. However, we tend to refer to normal tension in the context of open angle because what we mean by that is there is a problem with the drainage system there. It's just that the pressure hasn't raised as such with a normal tension patient. What we're saying in that patient group is the pressure that we're measuring is sitting at a very normal level, but unfortunately the nerve damage is happening at that level. So that's what it's referring to. It's about the eye pressure at the time of the glaucoma happening, the damage occurring, being actually quite normal. It might be sat, 14, 15 in a very normal range, but the glaucoma's there.
Right.
But yeah, you would normally use that in context with the open angle.
Wonderful. So next one, Rachel, is it possible or likely that open angle may develop into close angle?
So I would say no, except for those secondary causes. So, you could have an open angle glaucoma, but have another eye problem that then means it then closes off that drainage system. So that could be many things, as I say, even just thinking about those classic ones of a cataract forming, it might be that something then suddenly looks very narrow to us, but you've always been an open angle. So it can happen, but it wouldn't be a primary angle closure. It would be then, a secondary angle
Sure.
closure.
Great. Thank you. The next one. My consultant has given me a taptiquam. This makes my eyes very sore as I have surgeons. Is it okay to use it in the evening so I have time to get over the side effects before I have to do anything?
Well, I would say you are better off speaking to them if it's causing you bother for one, because the issue is with the if it's the tacticum that they've given you, often I think they will tend to say use it in the morning, which I'm presuming is what it's been prescribed as, purely because of the timolol component of it. So, that can do things like reduce the heart rate, etc., which you get naturally happening at night anyway. So that's often why people say to use it of a morning, and I assume that's the case for yourself. But it shouldn't be necessarily a problem to use it another time of the day. However, I would speak to your consultant team about it because, for one, obviously, if it's prescribed for morning, we generally say stick to that. But also, if you're having eye irritation, it may be there's something else they can give you potentially. Alternatively, if they can't give you another drop, then I'd be saying they need to look at what they're doing, in terms of managing those side effects, lubrication drops, etc. Because there will be some way around it that they can tweak medications, but do let them know because, say rather than struggling on and thinking, well, what can I do to resolve it myself and just change the timing of it? You might find even if you change the timing, it's still an irritant. So I would speak to them about it and see what other options there are for
Right.
medications.
Good advice. Next one. I have a cataract developing in the eye that is glaucoma. The cataract isn't bad enough to justify cataract surgery yet. Can I suggest that cataract surgery be brought forward because it might reduce IOP?
I mean, you could do, but again, whoever you're under will be weighing up, though, what are those risks and benefits. So the reason that it gets mentioned in terms of what we're talking about today and the angles being narrow is there has shown to be a lot of benefit there if you have a narrow angle because it's creating that space. If the angle isn't narrow enough and actually in terms of your vision, it's not affecting it significantly, then they may be less inclined to do that until you're ready. And that's the difficult thing. We say we'll operate on a cataract when you're ready. And what that usually means is when your vision has deteriorated to a point where it's affecting you day to day and it's bothering you. And that's purely because we don't want to dive in, most people don't, for surgery, and because we know there are risks. Even if cataracts is a really relatively safe surgery, it does always come with risks. So you can certainly have that conversation and mention, would it help my eye pressure? But they will probably be weighing it up about that risk and benefit, and if in your eye it is beneficial to do that.
Excellent, thank you. Next question. Right, bear with me 1 second. Is there any link between migraine and glaucoma, other than the possibility that a patient may take topiramate or another medication for migraine, and that could increase IOP?
Yeah, so I mean, it is something we look at in terms of other risk factors. So purely because we know people who get migraines, it may be related to circulatory issues. So anything where there is a possible chance of there being some sort of circulatory problem, whether that's diabetes, Raynaud's disease, something like this, then we worry about perfusion to the nerve. So yes, that could be something that is a factor. We always ask people about their, history, family history of things, but also what they are taking medications for, what they've been diagnosed with. And so migraines is something we would want to know about because there could be a risk there to the nerve. It could be that there's a circulatory issue. But yes, of course, as mentioned, it would also be what medications is someone taking for that. So yeah, there may or may not be, but it is important to tell whoever you're under, actually, I do have migraines, even if you're not taking those medications.
Okay, fantastic. Thank you. We'll move on to the next question. Does blood pressure medication have any effect on the eye?
So yeah, I mean, the issue with blood pressure and medication that you take for it, obviously, it's really important to get blood pressure under control. We don't want anybody to have a blood pressure that's too high. However, some of these medications can work really, really well. And I sort of mentioned before about blood pressure dips at night time. And sometimes we will do 24-hour blood pressure for patients to see whether or not they're getting those nocturnal dips. And actually, it is most often that they're on medications to reduce the blood pressure and they may need to potentially be looked at. It tends to be that we worry about this more. As I say, it's all to do with the perfusion to the nerve. If you are getting a dip in your blood pressure, you're getting less blood flow to the nerve, which can make it a little weaker. And that is something we'd be more looking at with patients who have this normal tension glaucoma, actually, because often in those patients, we're thinking, why on earth the pressure isn't so high? What's going on here? Are there other things that we need to sort of look at? So yeah, blood pressure medications, I would certainly say don't worry about taking them, but it may be something that we, have a look at if we think we're not sure what's going on here. What could be the other causes for the nerve becoming more damaged? And 24-hour blood pressure is something we do a fair amount of, ordering and checking with GP. It's very difficult, though, if we do find that your blood pressure is on the lower side, to justify raising it too much. So, it may be a little bit of discussion with the GP about titrating the blood pressure medications, but we have to be really cautious that it doesn't go the other way, because obviously that's not great for you health-wise at all.
Sure. Great. Thank you. Next one. What are possible causes for thinning of optic nerves? Would high myopia have a role in this?
Yeah, so we're talking in this particular talk about the narrow angles, and and I mentioned this kind of idea of a shorter eye and the issues that you get then with all the structures being closer together, and that's your sort of farsightedness. If you've got the opposite version of that, unfortunately, that can also cause problems because you've got this sort of differential shape in the eye where you have got then a almost pulling on that nerve and the structures. So yes, there is a risk there more for the open angle kind of glaucoma with having a longer eye as opposed to a shorter eye. So again, it's something that we're aware of, and they will probably be asking you prescription when you're seeing whoever you're seeing there. Not a lot you can do about it, but it's important to know if it is particularly a long eye, that's causing a different stress on the nerve in terms of the structures there.
Sure, thank you. Okay, next question. What is the recommended IOP for normal tension glaucoma? I have had trab surgery in both eyes.
Yeah, see, that is very difficult because the target pressure for everybody is going to be different. So everyone's target pressure, everyone's number will be different. I know you mentioned about normal tension glaucoma, and definitely in normal tension glaucoma patients, we do aim for the pressure to be a lot lower. And the example I was sort of giving before, if you come to see us and your pressure is mid-teens and we're seeing damage occurring there, well, we certainly want it a lot lower. And most providers are aiming sort of 25%, lower than what we're seeing when the damage is occurring. So quite typically, we may be saying to patients with normal tension glaucoma, we want your pressure to be, 10 or even under. But you'd really need to speak to your consultant, because obviously there's lots of variations in that, depending on what's going on with an individual. But certainly we might be aiming for very low. And I have had patients say after surgery, well, what's too low? And too low can cause issues. You can have this kind of folding of the back of the eye if the pressure goes really, really low post-surgery, that usually is. But actually, some patients will tolerate a relatively low pressure, and we may be wanting it to be that low. So, we've seen patients, under our care, maybe sat at 7 or 8, and we're quite happy with that. So you would have to speak to your surgical team and your consultant to find out, but there will be some ballpark area number that they'll be aiming for, no doubt, that they could tell you.
So everyone's an individual then?
100%, yeah.
Absolutely.
Confusingly, which is not helpful.
Sure. Okay, the next question. You haven't mentioned SLT treatment, which I had 9 months ago. Is this a proven treatment option?
Yeah, so the SLT though is for open angles. So we wouldn't do SLT laser for a patient who had narrow angles, because if the issue is before the fluid even gets to the drainage system, there's no point in treating that drainage system itself if the fluid can't access it. So the SLT laser is a laser that's working on the drainage system itself. So it is proven to be very effective. And actually now they use it as first line treatment because it's sort of got this stimulating restructuring effect that helps the aqueous move through those structures I was talking about before, the trabecular meshwork, Lanz canal. So where it works, it's great, and we see a nice reduction in the eye pressure. You're looking at statistically about 70% of people that will work in. The other 30%, we just don't get a response, sadly. We haven't identified which patients are more likely for that to work in, except for if you have the narrow angle type of glaucoma that we're talking about, in which case, as I say, it just can't even access that bit. So it's very effective. And if it does work, it can last a good few years before it wears off. And then we start to see pressure will go up as the effects of it are not long lasting. It's not a lifelong treatment. And we can repeat it where it's worked. However, like I say, in some patients, we just don't get that response. So you will see it now offered more as first line treatment, provided the eye is suitable to have it done, as in an open angle. And it won't last forever, but it may, give us a good few years off drops potentially, or reducing the amount of drops a patient needs. And then we can even repeat it, but it does get less effective the more you repeat it. So I can't say that, it works for everybody, but it certainly works for a good chunk of patients.
Great. Fantastic. The next question. What are the possible causes for thinning of the optic nerve? Would height... Oh, I've asked you that already. Sorry. Just a second. That's done. The next question. I'm taking tamsulosin for prostate symptoms. I've been told that this might be a problem during cataract surgery due to floppy iris syndrome. Can the iris become floppy before surgery, and might this affect narrow angle?
So the issue with the floppy iris syndrome is, it's just to do with when they take the cataract out. It can cause problems with making it a bit harder, because obviously we need everything to stay as it is in order for us to do the surgery. So it's not necessarily going to cause you problems beforehand, but I think it's something that they would be aware of in terms of doing the surgery. However, again, it's a needs must thing. And if you absolutely need that drug, then that takes priority. So I think, again, you'd need to speak with your surgical team if you've got any worries about when it comes to the surgery. But beforehand, I would say it's unlikely to cause you any issues in this, interim period until you're having any surgery. And as I say, if you need it, you need it, and we have to work around it no matter what that causes.
Great, thank you. Just two more questions, Rachel.
Mhm.
Cataract surgery resulted in lens being placed in font chamber. What effect might this have on drainage?
So I wouldn't have thought that's necessarily going to affect anything in terms of drainage, to be fair. So if you've got that just in a slightly different place, so I think what you mean is that it's not in its usual capsule, because you have a natural capsule that we usually just pop the lens into. And if we've had to place that in the front, that's not necessarily going to make any difference for the drainage. So it shouldn't be a problem. If there's any issues with the placement of it, then that would be slightly different, but that is what your team should be checking and, making sure that it is in the right place in that front portion and not causing any issues.
Great. Excellent. So, um, one more has popped in. Is it best not to have YAG laser?
Is it best not to?
Yes.
As in, under what circumstances, I guess, because the YAG laser peripheral iridotomy, well, if you have a narrow angle then and you have the pupil block, then absolutely it's best to have it. The issue with if we're talking about that ZAP trial, it was more about doing the YAG laser for patients who purely have a narrow angle, but they're not really at high risk of that angle closure. It's a little different if you've gone into closure or you've got an angle closure glaucoma, then absolutely they will be doing that because the angle closure has happened and we know the eye is at risk of that. If the angle is just narrow, then it's something that we'd want patients to be aware of. And so, there may be reasons why it is recommended, but we are, as I say, having that shift now towards not doing it just routinely for anybody who's just got a narrow angle because of what that study showed. And it is a very safe laser, but just a bit like I was saying with surgeries, everything has risks. So if we do the laser peripheral iridotomy, what we can find is it causes a bit of inflammation in the eye. You can get the occasional, rare risk of some bleeding in the eye, and it can also cause issues with vision. Again, that's very rare, but for some people, as that light is passing through, it's then got another area to pass through, not just the pupil, and some people get odd visual effects with it. So this is why I say we wouldn't just do it unless there seemed to be enough of a benefit there. And if the risk isn't high of having the angle closure, then we wouldn't do it. But if somebody's recommending the peripheral iridotomy, the YAG laser, then I would certainly say, well, ask them why if you're not keen to do it or you've got your reservations, because there's likely to be a very good reason why they recommend it, particularly nowadays how the guidance has changed slightly and we are moving towards not just doing it as routinely. So I wouldn't say not to have it, but I would say you need to know why you need it, and hopefully they should be able to explain that to you.
Great. So have that conversation. The next one, there is two left, and then we'll start wrapping up. Would SLT not be offered if eyes with a high iris insertion or narrow angles? What would effects be if SLT did go ahead here?
So I can't say definitely about the high iris insertion. I don't know for definite whether they would do that. The issue with the narrow angles is there's no point in trying to do a laser treatment to a drainage system that could be open itself, but if the angle is narrow and that's the true problem, it's not going to actually help with the fluid drainage because the initial anatomical problem still exists. So I can't say that they would absolutely avoid doing it in all cases, but generally speaking, if somebody has a more narrow angle or the anatomy just looks like the problem is the aqueous actually accessing the drainage system, there's no point in doing a laser to blast away at the trabecular meshwork to get that working a bit better if it's working already. But the issue is before that, if that makes sense.
Absolutely. Thank you. Last one. I am at end stage glaucoma, blind in left eye, very restricted in the right. My consultant has recently taken me off acetazolamide tablets, but I was content with the low pressure, sometimes 4 milligram, 4 mg. Is 4 too low?
Of the pressure, well, like I was saying before, it may not be. Some eyes can tolerate that. But the issue can be that you get this crinkling effect of basically the eye almost deflating, as awful as that sounds. And then what that causes is issues with vision. So often patients will have blurry vision with that. So for maybe tolerating some people, and I can think of plenty of our surgical patients where to begin with, we've got the pressure really low. And as you get a bit of scarring and the eye heals up a bit, it kind of increases and actually it's sat a bit higher than that. But the eye can tolerate a lower pressure, but it's whether it's bothering you visually. And I think if there isn't an absolute need to have it that low, we probably wouldn't have you on medications like Diamox or acetazolamide that give you all those horrible side effects potentially when we don't need the pressure that low either. So that could be why they've gone down that route. Again, you'd have to speak to them, but I would say 4 can be tolerated. However, acetazolamide is not the nicest drug to be taking. So, that is probably why they've said, well, if we don't need the pressure that low, then why have you on that drug?
Great. Is my screen showing my thank you slide, Rachel?
I can see it, but just not on my full screen, as in I can see your notes if you
All
like.
right. Bear with me a second. Let me just share properly. Won't be a second. You just bear with me. Great. Is that better, Rachel?
Yes, I can see. Yeah.
Fantastic. Excellent. Okay, I'd like to thank you, Rachel, for a great presentation and your answers to all the questions. It's fantastic to get through all the questions over the sometimes we've got a dozen left at the end. So for those of you who would like to make a note of our helpline number and email, it is here. The number is 01233 648170. The email is easy to remember, helpline@Glaucoma UK. Our next digital glaucoma support group is in October. It'll be starting a bit earlier on the 15th of October at 6:30. And it's all about appointments and what to expect and what to ask. We will have somebody with lived experience on this, so it'll be really good. And finally, we've got our Excellence in Glaucoma Care Award. So with our very special 50th anniversary birthday this year, we've decided to review our Excellence in Glaucoma Care Award scheme with a very fresh perspective. So we would like to acknowledge and celebrate the wonderful teams and volunteers at your hospitals or local sight loss societies or at your excellent support groups. As part of your glaucoma journey, have you benefited from the support and guidance of such a team? Support can come in many forms, such as advice on administering your eye drops, surgery options, emotional support if you need it, or advice regarding driving requirements. So as long as the support received has been above and beyond expectations, there will be details on how to submit a nomination on the email you will receive following this DGSG. So please consider completing the survey, which will launch at the end of the webinar. We want these sessions to be great, so the more feedback we receive, the better the sessions we will provide. And finally, before we go, I will do another poll, the final poll, and give you a chance to answer that. Give me a second. Sorry, I'm just having a problem getting the poll going. Okay. I'm having a problem with the poll, so we'll give that a miss. So I'd like to say massive thank you to Rachel for her presentation and all the answers. And thank you to you all, and have a nice rest of the evening. And hopefully see you again soon. Thank you.
Bye, everyone.
Have a great evening. Bye-bye.